All right. So we'll start talking about nasopharyngeal stenoses. This is another one of my favorites. It's such cool anatomy in the nasopharyngeal region. I didn't understand this anatomy till I started doing these cases more commonly. And so I was going to do a little bit of an anatomy review to try to reintroduce some of these ideas to you as well. All right, so what is a nasopharyngeal stenosis? It is some sort of pathologic closure of the nasopharynx. It makes sense, but where exactly is that? It's this cavity that's caudal to the choana, and it's above the hard and soft palate. And so when we're thinking about getting to this region, we kind of have to keep all of that in mind. And I'll show some images here that help kind of hit that location home. Most commonly, most of the nasopharyngeal stenoses we see are from benign reasons, and by far the most common is a post-spay rhinitis, or post-anesthesia rhinitis. And so we honestly see this in young patients most commonly because they have spay, dental procedures, and unfortunately they end up having a rhinitis, an aspiration rhinitis that happens after that, and they get a nasopharyngeal stenosis from that. Tumors are super rare. I've only ever placed one stent for a neoplastic obstruction of the nasopharynx, so that's a really, really uncommon situation. So I'm not going to get too crazy with this, especially after lunch. This is a lot to take in. But thinking about the borders of this region, you have this, you have the bones of the hard palate sitting ventrally, and then you have the nasal septum on midline, and then you have the surrounding bones of the choana. So when you think about it, the nasal cavities, left and right nasal cavities, are completely separate by a nasal septum until they get to the level of the choana, and then it becomes one cavity, becomes one tube. And then that's the point at which the true nasopharynx starts. And that's a little bit over the hard palate, but then that extends over the soft palate until you get into the oropharynx. And so we all know this, but as air comes in, it transitions down, epiglottis opens, and you come down into the larynx. Flip side, epiglottis closes when food comes in, and then that goes up into the esophagus. So I like this video because it actually helps me to think about it. Think about these pterygoid bones. You know, when you're doing an oral exam next time a patient is under anesthesia, think about where those are. You know, you pass your finger in, you fall off of the hard palate, and you hit the soft palate, but you feel bones. We call them sleds, you know, the kind of like bones that kind of come down. It feels like a sled. You feel those bones right there. Those are your pterygoid bones. That's where your nasopharynx is. And so when we look at this here, here's the end of the hard palate. So the soft palate is going to start right in here. But these are the pterygoid bones. And this right here is the region where most of the nasopharyngeal stenoses occur. And so as we watch this come in, we're going to get in here and kind of look, and we're going to see all the way up into the choana. This is me just doing this like with an iPhone like over his skull, so it's always less exciting than I think it's going to be. But this is where you go into the nasal cavities on the left and right side. So you're coming in, you're just starting to see the septum here, and so this is the true choana. And think about where that is in reference to where the hard palate is. You know, there's some room there. The hard palate ends, so it's cranial to the hard palate. And then after that, you have these two bones coming down, the pterygoid bones coming down on the side there. Thinking about the soft tissue component, the biggest thing to keep in mind is the soft palate. Again, if this is the end of your hard palate here, soft palate starts right at this region. This is that upper bone right here. Oops. This is this bone that you can't really see that great until you get kind of further down. It's this bone in here. And so these are all the areas you have to contend with when you're dealing with the nasopharyngeal stenosis. It's all right in this region here. And so the reason I'm kind of like hitting this home a lot is because it determines what kind of procedure you're going to do. Am I going to do a surgery? Am I going to do just a temporary stenting, a permanent stenting? How am I going to approach this? And so let's look a little bit at clinical signs, because I enjoy everything about this disease from the treatment and diagnosis standpoint. I don't always love the outcomes, but it's a really, really interesting disease how they present. So here's a typical pit bull that we see where it's really good at kind of hiding its signs. And let's see if you can hear a little bit. So other than you and the owner, people are not going to pick up on this. This is going to be pretty unusual. The owner's going to notice it because they're like, oh, this dog's really loud when it's just laying here and sleeping. You'll notice it because it sounds abnormal as their vet. But most other people aren't going to pick up on this. This is a really stoic dog who's hiding its signs. But the one thing you can pick up on is that sturdor that sounds like it's coming from the nasopharyngeal region. The other thing that's really interesting, watch close here, watch this dog's cheeks. It's sucking in the cheeks. It has such negative pressure. It's trying so hard to breathe in that its cheeks actually get sucked in as it's trying to breathe. And so this is a classic case for a dog that's really hiding its nasopharyngeal stenosis until it's really, really severe. And so the owner finally brought it in because of the sound, but then also this was a dog that was having a really hard time eating. So kind of again, coming back, thinking about the anatomy, you can imagine if you're looking here, that if you close this region down, this is nasocoena coming here into nasopharynx. If you close that down and then you have a dog that eats, now it's obstructing its other way to get air in. So now the air can't go through the nasopharynx. It also can't go through the mouth. They obstruct when they eat. So they get this gagging that happens. Everything stops because as they eat, they can't get air in and they're like, what's happening? Everything's blocked at the same time. And so it brings into the decision-making process of when you move forward with treating a nasopharyngeal stenosis. One of the big things is that if it impacts their eating, if they can't eat because they obstruct their airway every single time they eat. Because I will tell owners, if you look at these signs here, I will tell owners that you should not treat a nasopharyngeal stenosis for sturdor or for nasal discharge or for sneezing or even coughing because that might not get better. You're going to eventually do some things in this nose that's going to make the situation worse for a while. You're going to inflame it. You're going to potentially put a stent in. It has foreign material in there. All of that is not going to make those things better. You're still going to get nasal discharge. You're still going to get sneezing. You still might have sturdor. Those are not reasons to treat nasopharyngeal stenosis. What is, though, if they can't breathe and they can't sleep? Those are the two big things. It's really common. I'm sure you all have seen it. It's common for us to have these cases come in. They have to sleep with a tennis ball in their mouth. Some people will teach them how to take like a roll of tape and actually have them just hold a roll of tape in their mouth. Cats will sometimes sleep. I have some good videos of these cats sleeping in their carriers, and they lock their canine teeth into the door of the carrier so that it keeps their mouth open at night. And they're smart. So they realize, okay, I can actually breathe and I can sleep. That's not really a good quality of life. And so that they teach themselves how to do that because that's a way for them to actually sleep because then they can breathe through their mouth so that when they're falling asleep, they don't have to worry about obstructing. Here's a little bit more of a classic scenario.
All the places we can place a robot.
This is like a little bit of the gagging that we see. So this is a dog that's trying to breathe with its mouth closed, but when it tried to breathe through its nose, it can't. It can't actually get air in. It's trying to breathe, but it can't get any air in, so it obstructs it, and it opens its mouth. It gags open because it can't actually get air in. So the response then is for it to open its mouth in response to that. So I like thinking about these cases because it comes back all to the anatomy and thinking about the anatomy and why they're presenting the way that they present. All right, so let's look at how we start to diagnose these cases. The best way is CT. Radiographs really are not useful. The only way that radiographs help is if it's a true trauma case. So I've had a few of these cases that have been hit by cars where one, actually the owner saw the dog, ran out, his little Scotty, ran out into the street. As the owner saw the dog go sideways and the tire just drive over its head. And so we knew that there was like a massive trauma there. And so radiographs will help in that situation if you see like really big palate fractures or maxillary fractures. But the reality is when you get to the point of treatment, if you really want to assess these further, CT is really, really helpful. Rhinoscopy is good in the diagnosis of a nasopharyngeal stenosis in that you notice if you do retroflex rhinoscopy, so you come into the mouth, retroflex or use a flexible scope, look up over the soft palate and up into the choana, you'll see that there's no opening there. You should normally be able to see all the way up to the choana. So you can diagnose it that way, but it doesn't really give you a view of how severe the disease is. So let's run through this here. So we'll start rostrally at the nostrils, canines coming in there. Everything looks okay so far. everything's fine. So you have the turbinates. Start to see a little bit of fluid there. And then this is where things change. So right here, here's our choana. Right here's our choana. So we can still see hard palate. We see the bilateral nasal cavities coming in. Hard palate, choana. And so air could still make it through there, could still make it through there, could still go. But now, where's the opening? There's no opening. So we have mouth, soft palate. There's no opening dorsal to the soft palate. So at this point, air cannot get past that point. You start to see these pterygoid bones right here, these two sleds coming in, but air can come in through the nostrils, both nasal cavities, into the choana, and then it stops because the soft palate is completely up against the dorsal bony wall there. And so that's the start of your nasopharyngeal stenosis. If we keep coming caudally, now you can see it open. And if we come all the way caudally, this is the end of the soft palate. Soft palate's now opening into the oropharynx. And so going cranially again, soft palate, that all looks okay, that all looks okay. That's all fine right there. So it's just a very short section right through there where it closes down, right in between those pterygoid bones. And that's the most common spot. This is a aspiration rhinitis that happened during a spay procedure. And so it caused enough inflammation there where that soft palate got inflamed, and then it stuck up to the roof of the nasopharynx there. This is what it looks like in lateral. So again, everything looks good back here. You have your soft palate here, hard palate here, nasal cavity. Everything's fine in the nasal cavity and the hard palate here. Soft palate back here looks fine. But right here, this soft palate is adhered up dorsally to the bones up here just underneath the calvarium, underneath the skull here. Same thing back here. So this is it in one cross section. If you look at it in another cross section, you can see that it's a longer region that's affected. Rhinoscopy, this is a common thing we see. We see a ton of fluid building up back there from all of that inflammation, so you can't even see any kind of opening here. You just barely see a little opening up here on this one. This is just looking at the scope. And remember, since the scope is retroflexed, everything is upside down. So this is the soft palate here, and this is dorsal. But just looking up there, we barely see any kind of opening throughout that length there. And so one of the big things to determine is, once you get that scope, is to try to determine if it's open or closed. And the big reason is that usually the closed ones oftentimes don't respond to just ballooning. So we will tend to stent those, either temporary or permanent, really quickly afterwards, right afterwards. All right, so now we've established that there's a nasopharyngeal stenosis. The clinical signs support it, the imaging supports it, maybe you've even done a scope and that supports it. So now you look at what the options are, and there's a kind of a list. Surgery is an option, something to think about. Balloon dilation alone is an option, or some sort of stent placement. For surgery, I usually reserve surgery for bony stenoses. So either dogs that were born have a congenital bony stenosis of their choana, or dogs that have a fracture where it's so bad that it's collapsed all the bones down. The reason is, if you come and you do this case that I just showed you the CT of, this one where it's all soft tissue stenosis, and you go in and you cut through the soft palate, you peel it off, that dorsal bone, and you try to suture everything back together, you're essentially just doing exactly what that case had. You're just inflaming all that tissue again. And the best case scenario would be if you could actually suture on the dorsal side, but you're coming in from the mouth. And so maybe better surgeons than me could do this, but I cannot get up there and try to suture that dorsal part. That dorsal mucosa is you can't even see it. So you'd have to be lucky in getting that to reoppose. You basically need to directly reoppose mucosa to mucosa and not have any inflammatory tissue sticking out. So it's really hard. All that to say, I usually, if with any soft tissue obstructions, I don't do surgery on those cases. I usually reserve it for the bony ones. So here's an example of that. Here is a case that had, this is another one of those cases that got hit by a car, had a collapse of all of those bones. The vomer bone was coming in, the maxilla was collapsed, part of the palate was collapsed. And so I usually go in those cases, I have them in dorsal recumbency. I'll do a ventral incision through their hard palate. So if you haven't done that before, it's actually a pretty straightforward procedure. Basically, they're in dorsal. You do an incision directly on midline on their mucosa, that line in their hard palate. that peels away really nicely. You just get some Gelpi retractors in there, some self-retaining retractors in there. It holds it open. You see the bone there, and you can drill the bone away. So if you have a bone drill, you could take that bone. They don't really need the hard palate along its full extent. As long as you have the mucosa there that's able to cover over it, you can take away a lot of the hard palate. And so I'll just come in there, and you can kind of see in the images, I've exposed the right side in this particular case, and then on this one, most of the trauma was on the left side of the dog, exposed the left side of the dog. And so I've opened up mostly the left side in this one, so I've gone all the way into the nasal cavity. But I'll just take a drill and remove as much of that tissue as possible. Here's another example. This is that little Scotty I was talking about. And so what you can see on this one, this is a good example before I've taken out all that bone. So here is that dorsal bone that's sitting up underneath the skull. Here's the soft palate that I had to incise to get back into there. All of this, if you look close, you can kind of see how all of this bone in here looks very abnormal. It's all kind of has little kind of juts coming out of it and just all abnormal and in a weird shape here. And so this is all of that collapsed bone that's been collapsed down into the nasopharynx. And so I'll just take a drill in there and just remove all of that. They don't need any of that bone. You could just take all of that out. Essentially, you're cutting into both the mucosa on the hard palate and the soft palate, and you're opening up that whole nasopharyngeal region and creating a large hole there in the bone, just removing any abnormal bone. And so this is one where I did that and then temporarily placed stents, so you can kind of see the first part of the temporary stent coming in there just to see how open it is. But that region here, I wanted to take out, and we took out more of this bone, so we basically open up all of this region here, create a new opening, suture the soft palate closed, and then suture this mucosa on the hard palate closed, as a Karen, Terry, not a Scotty, sorry. All right, so what if it's more of a soft palate, or sorry, a soft tissue obstruction and not just a bony obstruction? You can balloon dilate. So usually balloon dilating, I usually reserve for those cases that have some opening still. The ones that are completely closed down, I usually don't plan on balloon dilating working long term. And so balloon dilating, again, I usually make a plan if I'm going to do just that of treating them 3 times in 1 week. So we'll try to get them in, either a Wednesday, Friday, Monday, or Monday, Wednesday, Friday, but we try to be aggressive with it. Same equipment that we've been talking about all day. We use fluoroscopy and endoscopy, guide wire to get access. One thing I'll show you is some new access needles, introducer sheath, and then a balloons. So you can use anything that gets you across the obstruction. So basically how you're starting these procedures is that you're starting from the nostril, you're passing whatever the device is through the nostril, and you want to get it past the nasopharynx into the mouth. And so in a bony obstruction, that might not be possible. In some of these soft tissue obstructions, it can be really challenging. And so you have to kind of think about which of the different items do I have, and it doesn't matter. It just has to be something that has that's cannulated, something that has an opening that you can pass a wire through. And so what I mean by that is that for very small dogs and cats, I'll just use a typical IV catheter. Because if I pass that through and get that past the nasopharynx, and I have enough room, all I need to do is get enough opening that I can get a wire to pass through. And so an IV catheter is fine. For a little bit bigger dogs, I'll sometimes use those pericardiocentesis needles, those like 6 to 18 and 16 French needles that are, 6, 8, 10 centimeters long, the ones that we do percutaneously for that. I'll just use one of those because it's a little bit longer. And so that's a really nice option. You can use spinal needles because they make really long spinal needles. In big dogs, I'll use this. I'll use a locking loop catheter because it just has a really nice setup. So this is what I showed earlier as far as when we use it for a cystostomy tube, but it has multiple components. It has the catheter, the stylet, and then it has a needle. And so you can use that in any way you want. You can use the actual needle to puncture through. If there's no opening, you have to open it somehow, so we'll use the needle of that to actually create an opening. But it also has the stiffness of the stylet, but also can leave the catheter in there. So it's a really nice option. So you can either use one of these like typical locking loop catheters or just any kind of device. They have like hepatic puncture needles, all sorts of things cholecystostomy tube needles, all of those things. You can kind of choose and select. You basically just need to get something in there that's going to allow you to get a wire in position through the nasopharyngeal stenosis. I like these, again, just because I use the needle part. As I push this in, a needle comes out the end. So you push that in, a needle comes out the end, and you also have a stylet, and you can pass a guide wire through the stylet, so it's a really stiff device. So if you get this past the obstruction, you can get a wire in and get it down. Because your goal is essentially when you pass a wire from rostrally across the stenosis, you want to grab that wire in the mouth. So you actually want to use, I usually use a spay hook or something. I'll usually just open up the mouth, hold it open with a laryngoscope, grab the wire with a spay hook and pull it out the front. Because again, as we talked about a lot today, if you get both sides of the wire, you're definitely winning in that situation, because you have the wire coming from the nostril, and then if you have the wire coming out the mouth, it gives you both options for trying to get over top of that wire. It also lets you stiffen that wire to pass things over it. And so that's the goal, is to try to get it through and through. So here's an example of one of those locking loop catheters coming in. We have our scope here, and we've just gotten that access needle past the obstruction. I again like to use fluoro if you have it, or you can use DR as well to watch it alongside with your scope. It's nice to have both options. Okay, you can use either an 0.18 or an 0.35 inch hydrophilic wire. I would encourage you to try to use an 0.35 inch just because it's stiffer and bigger, and so it's not usually a matter that the hole is so small that the wire won't go through. It's usually that it's a complete obstruction or you can get the wire through. So try to use the biggest wire you can that also lets you pass over it what you need to. And so here the scope is doing flexible rhinoscopy. So we're looking up again, top of the soft palate, up at the choana, and the wire's now coming through. So we've gotten through the nasopharyngeal stenosis, and this is then coming out into the mouth. And so this is what it looks like. This is not a sterile procedure, so we're not draped in. Here's the wire coming in through the nostril. It's coming down through the nasal cavity, through the nasopharynx, into the mouth, and then we're grabbing it and having it come out the mouth. So we have it on both sides here. You can pass it down the esophagus, but you lose that advantage of having both ends of the wire to be able to use that. So I've gone away from doing that, and I always try to pull it out of the mouth now. So once it's out of the mouth, you can place your sheath over top of the wire. And so the sheath comes transnostril again as well. So you're going to take it all the way in over the wire, and you're going to pass the sheath in till that gets past the nasopharyngeal stenosis as well. So again, you can see how inflamed this area is in here from the stenosis, and this sheath is now over the wire, and this is over the region of the soft palate. We're scoping again so we can see this sheath sitting in that region. It helps to dilate, open the stenosis, but it also allows you to pass your balloon in there, because the balloon again is really kind of floppy as you pass it. So if you have the sheath in there, the sheath again, just like for the percutaneous ureteral stents, it's a means of getting your balloon into position. I say here that you can infuse contrast to determine the location of the obstruction. I would really try to avoid doing that. When you're infusing back there over the nasopharynx, next spot that it's going to go is down. And so it could go down orally, which is okay, but it also could go into the respiratory tract. So if you feel the need, like you can't tell where the stenosis is, you can do that, but you just have to really pack the back of the mouth so that you don't get any of that contrast that goes down. I would say as much as you can avoid doing that, I don't remember the last time we actually infused contrast into there. It's really unusual. All right, so then again, balloon dilation, it's something we consider for these soft tissue obstructions. I don't use it ever for bony obstructions. I think it likely works best by itself for incomplete closures. And a high pressure balloon, similar kind of idea that you're going to use oftentimes some of these cardiac balloons to actually position it and placed over a guide wire. So here's an example. So coming in over this guide wire, we're watching with the scope. You're going to see the balloon come in over top of the wire here. Here it is there. And since it's a long enough balloon, that was a pretty small obstruction in the example I showed. So that obstruction was probably only at 1.3, 1.4 centimeters, like 10 to 14 millimeters long. So if you're using a balloon that's 3 or 4 centimeters long, you're going to have a decent amount that's covering it on both sides. So I usually will pass the balloon in till I can see it. And so here's the balloon tip coming in there, and then the actual balloon is starting right here. So this is the balloon coming in. You can kind of see it there. And I'll check it with fluoro. So we'll start by inflating it with fluoro. are watching it as we inflate it. I'll watch it with fluoro as we inflate it. And same kind of idea, where if we stop like it looks like in that first image, we're not actually breaking down the waist. We're not going to get that stricture to completely open up. And so we like to see it all the way to the end there, and this isn't a waist that remains. This is just where it deviates above the hard palate, so it's getting compressed up into the choana there. But the waist there, we actually could see the waist disappear, and I'll show a video here in a second that shows a really nice example of that. But you want to see that balloon completely open up so that you break down that strictured waist that's in that region. And so here it is again, just kind of blowing up, and then once it's done, we want to remove it, and then we hope that we've at least opened up that area pretty significantly. And sometimes it's hard to tell because there's significant bleeding that happens afterwards, and so it can be a little bit tough to tell how much impact you made. So we try to suction it out as much as we can and then see what the impact is. And so for us, we've gone away from ballooning alone in the majority of cases. We usually will decide to either permanent or temporary stent. Most of the time if we balloon, we usually temporary stent in the meantime. And so there's a couple ways to temporary stent. And so this is where things can get a little bit confusing just from the terminology. So when I think about temporary stenting, we have options of using things like red rubber catheters, which I'll show you here in a second. And then permanent stenting, we can place these metallic stents that are never going to come out. There's also this middle ground option, kind of back to some good points that some of you raised before. There's a middle ground option where there's a covered stent that's actually a removable metallic covered stent. And so that's the third option. So you can kind of go for whichever one of those you feel is most appropriate. Usually if it's a balloon, and I think that I'm going to be able to balloon and hopefully just need ballooning, I'll usually place just a tube stent, like a red rubber stent. If it is a case where I think that probably it's not going to last long term, I'll usually place one of these temporary, or one of these removable but metallic stents in that situation. If that were to fail or collapse, then I usually would go with a strictly permanent stent, which is not covered and is going to incorporate into the tissue. All right, so how do we determine, if we're talking about these metallic stents, we usually determine sizing from the CT. So coming back here again, we've done our length measurement. And so most of the time these stents are going to be much longer than the affected region. The affected region is usually pretty short, the length of it. Measuring the diameter is much more challenging in these cases because you see what the choana looks like here. It's not like a reasonable thing to measure off of, right? You look at this is going to be like 25 millimeters in diameter and probably like 5 millimeters in height. And so your stent still is going to extend up into that region. It's going to go into one of the nasal cavities. What I use more is kind of this diameter here within the pterygoid bones because that's where the majority of this is going to sit. Again, over the soft palate, it's a challenging spot to measure because it's so mobile. So it's not like a true diameter that's there. You can grab the soft palate and pull it down and make that diameter much more than what it would be. So the region that's most reasonable to measure is usually in this pterygoid region. And so here's an example of a temporary. So this is a temporary that I placed in that Cairn Terrier before. So after I drilled out the bones, I have typically placed these red rubber catheters afterwards because when I close down the soft palate afterwards, I worry that they are going to stricture down. So that's going to go from a bony stenosis in these trauma cases to being a soft tissue stenosis just from the trauma that I caused during the procedure. So I'll place these big red rubber catheters side by side and I'll have them come all the way out the nostrils, and I'll show you how we manage that in a second. And so we started by placing these for these surgically treated nasopharyngeal stenoses and had some success, so then we started placing them for our soft tissue stenoses, nasopharyngeal stenoses that were not having surgery. And so very similar procedure. Again, you get a cross with your wire. You place your dilator and your sheath across to get a balloon across. You're still going to balloon dilate them, and then we'll place these red rubber catheters. So here's just an example of that coming in. We can place a dilator inside the red rubber catheter, but that's just going to go down over a wire. And this is just a balloon, or this is a bilateral red rubber catheter. We have one going into each nostril. And so this is a temporary option, and as that's being passed in, here's one already in here. And then here's the second one coming in over a wire. And so we'll just place these and we'll have these kind of extend out over the soft palate again, as a temporary option, just to try to keep that region open for a short period of time. That's what it looks like in the end. So this is at the level of the nostril. So we pass them in all the way until the whole nostril is filled. This is back on the soft palate side. So that's the end of them sitting back on the soft palate. And we leave them there, and we try to leave them in for 6 to 8 weeks. We presented this at a conference just with some early outcomes. It's technically successful in all the cases. We did reestablish nasal airflow bilaterally or unilaterally in 4 dogs, and one bilaterally in 4 and unilaterally in 1. So it does seem to help in these cases. I'm going to get to how we secure them in a second, but I'll just show you this wild image next. So this is also another thing that you can do. So similarly, these cats that get the stenosis just truly of their nostrils, you can do a similar type of technique with those peel-away sheaths. So this is one of those sheaths that you put in, and then same as we looked at for the perineal access. Remember when we looked at the perineal access and we peeled them apart? Same type of technique. You place these sheaths and then this way, and these cats that have like no noses, it's a really nice option because they have plenty of room to suture them in place. And so we'll do this and leave them for these nostril stenoses and then leading back to the nasopharyngeal stenoses, again for 6 to 8 weeks, and then we'll pull them out. This is how we started securing them in dogs. So this was the first case that we did, and this was my idea, so I'll take credit because it was not a good idea. And so this is, I was like, oh, so much work to get these catheters in. I definitely don't want them to fall out. So I cut both ends and flared them up and sutured them with like 1,000 sutures. But what happened was this dog got really, really severe dermatitis underneath where all those catheters were. So they definitely didn't fall out. That was successful. But the dermatitis was so bad underneath that I didn't do that again. So I just started to do this after that case, and I like this a lot better. So this, I just leave the catheters directly right at the end of the nostrils, bite into the nasal planum through the catheter, and just leave that in place. So usually 5 to 7, 5 to 8 sutures kind of all the way around is all you need. And so the nice thing about that is that you don't even need to sedate them for removal. This is after one has been removed, so not too bad. The other one's in there, but this is obviously a really nice dog, but this dog just let me just do it awake. So just kind of cutting those sutures, and you're able to pull this. So if you can leave this in kind of for a 6 to 8 week period and let that be a temporary, I could actually just grasp it here and then pull it out, and tolerated that really nicely. So it's a nice option for like a minimally invasive placement, pulling it out, and then as a way to try to prevent them from re-stenosing down afterwards. So we like this in some of our cases, some of these balloon, ones that we balloon open and then want just temporary placement. I'll look at then a true permanent placement. So this is the opposite end. So if we have the one end, which is just these temporary red rubber catheters, the other end is the permanent, and then we also have a middle ground option here. But here's a permanent placement. So this is actually a balloon expandable one. So this was an older one that we did where we used to place these balloon expandables. And so in this case, these are not going to come out. These are going to be uncovered. This is going to be totally incorporated within that tissue, and it's going to stay in position. And then this is just pulling the balloon out afterwards, and you're going to see the stent really nicely. Again, the nice thing about the balloon expandable is you see really good contact that the stent has with the wall. It's totally engaging the wall in all aspects because that balloon really expands it out and pushes it all the way up against the wall. And that's what it looks like afterwards in that region. All right, so then where we are most commonly now is we're using these covered self-expanding stents that are technically can be temporary, but you can also leave them in permanent. And so the reason that they can be temporary is that they have a covering over them that prevents them from incorporating in really heavily. They also have a little tab on the end that you can grasp and pull it, and the stent's going to unravel and basically come out. And so here's an example of a deployment of that one. And so you can actually see, if you look close, you can see the covering kind of on the stent there. Sorry, there's a big delay here. Here's the stent opening up, and you can see the covering here. And so as the stent continues to open, there it goes. You can see the wires now And you can see that really contact out nicely and engage out into that wall. You can actually then scope all the way in caudally. And there's another video, sorry, I want to show you. Here it is. So one thing about these stents, these ones that you put in that have the covering, is that they can migrate. So again, kind of coming back to these stents that have a covering, one of the issues with them is that because they have that covering on them, they don't engage or incorporate into the wall, so they can move as the patient coughs or has any kind of aggressive movement there. So we'll actually place these T-fasteners. And so what T-fasteners are is that they're essentially a little metal bar attached to a suture. And so you picture like this metal bar and this suture is loaded into a needle. And so basically it's in there so that if you push something into the needle, it's going to push that metal bar out. The metal bar is going to pop out, and it's called a T-bar or a T-fastener, and that's attached to a suture. So we'll pass that through the soft palate into the stent, so inside the stent. So you get that T-bar that pops out, and then you can suture that down. So it's going to hold the stent in place. So it was designed for doing gastropexies, temporary gastropexies in humans. So this is what that example is here. But here's that T-fastener in there. So it's a little metal bar, and I have two in there, and I'm watching with fluoro. Here's the stent in position. And I'm just watching with fluoro as I'm pulling these down. And I'm basically going to pull these down to the point where they're tight up against the stent, and then I can actually secure them down to the soft palate. So here I'm tightening them up, I'm pulling them up, I'm watching with fluoro, and then also I'm intraorally pulling them down. So let me show you that whole process. This is the whole placement kind of to cover all these different steps. All right, so now bilateral access, so we've gotten into the right nostril. The left nostril has this sheath in it, dilator in it. We've passed the wire down. This is my fellow, and she is grabbing the wire from intraorally. So the wire is now going down into the esophagus. So she's using a spay hook here and a laryngoscope. She's actually going to grasp the wire. Here's the wire coming out. Again, it's not a sterile procedure, so we don't drape them in. So now we have wire through and through access, through the nose, coming down, out through the mouth. So here's a fluoro view of that. Two wires here. We have one in both sides. So here's one coming down, wrapping around the soft palate, and then coming out the mouth. And so this is at the point where we're ballooning. So if you look close, this is a balloon in there. And this is a really good example of how you have to take down that waist. Really nasty nasopharyngeal stenosis here, tight waist in there. And so we're going to keep blowing this balloon up. It took us several balloons to get to that point. And finally, we get to the point you're going to see it actually give and totally dilate. So that was one more. We're going to go after that. And there we go. And that's the dilation. So now we're coming in with the stent. And so here's the stent opening. So if you look really close right here, stent is starting to open. And so we've mapped out where we want our stent to sit based on our CT and based on our balloon dilation. So that's the area right there that's most affected. And you can see that's where there's still a little bit of a tightness to the wire or to the stent there, but we've gotten it pretty open through that region. And so then we're going to come in again with these T-fasteners. So it's a needle. The needle's going to puncture the soft palate, puncture into the nasopharynx. If you look really close, you can see those little T-bars coming out. And then you basically end up with two sutures intraorally, and then I tie those up to the soft palate. And basically I'm just putting those T-bars in there, tightening them down to hold the stent in place, and then pulling them up. So as far as outcomes, it tends to be really good. Any kind of nasopharyngeal stenting that we do, it tends to be really good for air passage. Like I said, I don't usually use this as a treatment for nasal discharge and sneezing because it's not unusual for them to maintain that. The biggest things, and I think a lot of this has gotten eliminated when we've gone to these covered stents, is this ingrowth through the stents and reobstruction. I think that that's helped quite a bit. Oronasal fistulas, I've seen this happen in two cases. So one with a temporary stent that I placed. This was also one that I had done surgery on. So basically, it's less an ora nasal fistula. It was an ora nasal fistula, but it was more so a dehiscence from where I had closed things down. So there's a little opening there. And then I had one cat that I placed a stent in that also had an ora nasal fistula. That chronic fluid and mucus accumulation, you can still see that in these cases. So we will commonly do nasal or saline flushes intranasally as well to try to keep that from opening. Or to try to keep that from getting mucus accumulation in there. Migration and fracture. I've never seen a fracture. Migration, I don't think I've ever seen a migration either. More so, I just worry about these newer stents where if you don't secure them in place, potentially having them migrate. And that's it for nasopharyngeal stenosis. Any questions on any of that? It's quite a fun procedure to do. Yep. Question?
How do you choose the measurement of the value that you are going to use? You use the same image that you show us for the stent?
Yeah, for balloons? Yeah, so the question is what size balloon do you pick? You have a lot more freedom here. So honestly, I'll just start small and then work my way up. So most dogs, I'll usually start with like a 4, 5, 6 or something in that region. And then, because the thing here is that it's a low risk ballooning. You know, you can see it really well. You're not going to expand beyond what the bones are. So I usually start with a small balloon, see if that got me enough, and then I'm like, if I can go bigger, then I'll usually go up. I don't think I've ever gone like above like 10-ish or so. But some of the stents you put in are 10, 11, 12. So yeah, I probably have gone up to 12. Because I usually, if I balloon dilate and then put a stent in, I balloon dilate less than the diameter of the stent. Because I don't want to dilate up to 12 and then put a 12 in. Probably would be okay because you probably like don't really get it up to 12, but I usually will dilate up to 10 or 11 and then put a 12 in just to keep the risk of migration down.
And I think you said you use like high pressure balloon.
Yeah.
Do you inflate them with the manometer?
Yeah. Yeah. So the question is, how do you inflate them? I always forget what the term is, but it's basically, yes, I use one of those really high pressure devices. Do you know what it is? Manometer. Okay, yeah, sorry. Yeah, basically, you just hook it up. You know, it has a little lure lock on it. Lure lock goes directly on the balloon, and you can, you usually crank that thing closed, and then you can just really get it up to the point where you watch the atmospheres. And I don't worry about bursting it, like I try not to, because then I waste a balloon. But if I do burst it, it's safe in this area, so I'm not really that worried about it.
So you just train yourself like the horoscopy and the weight.
Exactly. Yeah. So if I'm not breaking it with the size that I'm at, I'll just go up a size and then just go and do it again. Yeah. Like if I get to the point where I'm at the burst or below the burst, but at the maximum atmospheres, I'll just take it down and then do the next size up balloon.
Sorry, it's me again.
Yeah, that's great.
An unrelated theme. Our colleagues in France are starting to use these laryngeal stents.
Yeah.
Have you had any experience on them?
No, so the question is about laryngeal stents. I'm sure, I don't know. He's not in here right now, but I'm sure you'll hear about this later. I have not used them at all. I know Dextronics. I don't know if they're selling them yet or not. Are you selling them?
Not here yet, but
not here.
We will have displayed in the showroom with this laryngeal stent.
Yeah, I haven't placed any yet. Yeah, there's a couple. There was at the Endoscopy Society meeting this year. There was a presentation on it, so I saw them. They look really interesting. I just haven't placed any yet. Yeah, it's definitely a hard stent to make. So I'm curious to see how things play out. Yeah. It's a really challenging. I mean, in theory, it sounds good, It's just a really hard stent to make and have it work and not have it migrate and have it be the right size. So yeah, I hope it works out. Yeah.
¿Hay más preguntas? Vale. Os recuerdo que ahora abrimos el showroom con el display de los productos, que estará abierto toda la tarde, mañana también, y el programa es el mismo allí, o sea que podéis elegir si queréis ver los productos hoy o mañana. Como se solapa con las charlas, pues a vuestro criterio podéis seleccionar si queréis ir hoy o mañana, ¿vale? Entonces, volvemos a las 16:45. Vamos tarde, pero acabaremos a las 18:30 igualmente. ¿Vale? Gracias. 16:45.